Hi guys, John Rothery, Osteopath. I've been asked to show you some taping techniques for Achilles tendonitis, or tendinopathy as we call it. As a footballer, if you increase the load too much, for example, your training's too hard, too quick, so you push the mileage or the intensity, then you can get swelling around the tendinous area here. Also, if you're not warmed up properly, for example, you can actually rupture the Achilles tendon. And the tests we do to see if a tendon is ruptured is we do the Thompson test. So all we do is squeeze the lateral and medial gastrocs together in soleus, and you should get this movement here. If there's no movement of the foot or plantar flexion, then we know there's some sort of rupture, and that would require surgical intervention. But what we can do to tape the Achilles and take the pressure off it is use K-tape. So we put the foot into dorsiflexion. You can get insertional Achilles tendonitis, where the red star is. It's less rare to get that, more rare, sorry, but actually the insertional or mid-belly Achilles tendinopathy is more common, and that's because it's avascular. So what we do is get a long strip or an ice strip, peel it back, place it on the calcaneal heel, pull the tape back, try not to get the tape sticky or dirty, lay it down with no stretch, and then what we do then is we get two lugs, pull the tape back, again, lay it on the calcaneal heel, and what we're trying to do is support the lateral gastroc, which is this side here. So we put on about 70% stretch, apply it on the outside or the lateral gastroc. This one, again, 70% stretch, lay it down. Okay, and then this one is like a plaster. We split it in the middle. We apply stretch to about 120, and then we back off to about 70%, and we put it over the point with pain, which is the insertional area here. And what that does, it just takes the load off. So with your physiotherapist at your football club, you might do some eccentric loading, so you go fast up and slow down, maybe on your tiptoes, to increase the tensile strength of the Achilles and build up the collagen. As we age, you tend to find the collagen becomes weaker, and sometimes it can rupture or cause micro tears. And often people in their 40s tend to find that quite common, and more common in males. And you get the swelling around the Achilles area and pain and stiffness in the morning. So massage the area helps to reduce all the swelling around the area, ice, compression and elevation. The taping offsets the load, and then with your coach or your physiotherapist together, you do plyometric loading and eccentric loading to strengthen this Achilles. Hi guys, John Rothery, Osteopath. I've been asked to produce a video to help with you understanding taping of an ankle inversion injury. So often as a football player, sometimes you plant the foot, maybe get caught in a divot, and the foot inverts. There's three types. The grade 1's sort of mild swelling, discomfort. 2, lack of proprioception, so a grade 2, you obviously can't feel your foot in space, and a grade 3 is a complete tear, which probably would involve some surgical intervention. The first ligament is here. We call this the anterior talofibular ligament, and the one back here is the calcaneofibular ligament, and they're the two most commonly ones that are strained. So we get the patient to put the ankle into neutral. Again, we use an ice strip, so we create a stirrup. And what we do is we're going to cover this area here on stretch. And again, on the next one, we're going to feather it. So we're going to just place it slightly off at an angle. And the whole idea is to cover both ligaments. What we're actually doing is trying to create some eversion. So we're stopping it from rolling in again when you're playing football. The final piece is we cover both ligaments. So again, we're just here where the anterior talofibular ligament is and the calcaneofibular ligament, and we're just going to lay it on there, wrap it around the back of the calcaneal heel, and that's ankle taping. And what it's going to do is stop that ankle rolling in, and it's also going to make the patient or the player aware that the ankle is still not fully stable. So once you've done this, we'll progress on to doing some proprioception and balance work with your coaches or your physios. Hi guys, John Rothery, Osteopath. I'm going to talk to you today about thumb injuries that you might experience in football. Often with football players, they tend to fall with an outstretched hand. We call that a fouche. And what you tend to find is the thumb hyperextends and abducts. Just from an anatomy point of view, we've got the carpal metacarpal joints here, and this one here is called a metacarpal phalangeal joint. And what tends to happen is this ligament here, you've got the ulnar ligament here and the radial ligament, and what it tends to do is become really painful when you palpate or squeeze it. It's quite important to know the wrist movement. So examine the wrist, we turn it over. If you drop the wrist down, that's flexion, and the muscles involved will be flexor carpi ulnaris and flexi carpi radialis and palmaris longus, which is a muscle that runs down here. Extension, again extensor carpi ulnaris and radialis, and then what we've got here is where the thumb goes in, we've got radial and ulnar deviation. From the thumb point of view, we've got flexion, so if you thumb across, extension, adduction and abduction. And we've also got opposition, where we can touch each finger in time. So what we tend to do to tape the thumb, we don't want it to go into hyperextension again. So again, like with Achilles, we're trying to take the pressure off this area, and a bit like with the ankle we just showed previously, we're trying to make sure it's in this position here. So what we do, we've got two landmarks. We've got the radial styloid here, and the bony prominence here is called the ulnar styloid, and we tend to create an anchor where we just tape around here a couple of times, not too tight. And then what we're going to do is a figure of 8 to help support the thumb. So we come down through here, around that metacarpal joint, again across the wrist, back around here. Just hold it there for me, Des, just relax. Okay, again around here, keep it there for me. We can go around here twice, so we're stopping that hyperextension. And what we got there is support for this metacarpal joint so it doesn't hyperextend. You can put more tape on there, make it a bit more secure. It depends how severe their injury is. But this is obviously how we tape with a figure of 8 to help that stop that hyperextension. So we're offloading this ligament here that's been sprained.